Yes, so as mentioned, my name is Dr. Rachel McGuire, and this presentation is generally about skin and caring for skin in pregnancy. See if my slides will move. Bear with us. So just to outline what I intend to cover in this presentation. So first we'll talk about the normal skin changes in pregnancy, skin disease in pregnancy, then we'll cover menthol, its use in the relief of itch, as well as in pregnancy, and then just very briefly talk about antimicrobial lubricant. So it's important that we first know about the physiological skin changes that occur in pregnancy. And as mentioned, I think it's really important, especially for those community-facing midwives who tend to become sort of the point of contact for all of these women and all of their questions about their skin. So most skin changes in pregnancy are considered to be physiological, and they occur due to hormonal changes, immunological factors, and metabolic changes in the mother. And they can be broadly divided into four main categories: pigmentation, striae, vascular changes, and glandular changes, and I'll cover each of those in turn. So starting with linea nigra, which is physiological hyperpigmentation of pregnancy, and that's a darkening of the linea alba, which is a connective tissue that runs down the midline of the abdomen. Classically, it occurs from the umbilicus down to the symphysis pubis, but it can extend up higher to the xiphisternum. It's commonly seen in the first trimester, and it tends to increase in width and intensity as the pregnancy continues. Other pigmented areas of skin will also become darker in pregnancy, so the axilla, the inner thighs, the genitals, the periumbilical area, and the areola. And the degree of hyperpigmentation varies from woman to woman, but it will be more pronounced in those with darker complexions. Another example of hyperpigmentation is something called melasma. So that's symmetric, blotchy brown hyperpigmentation that occurs on the face, and that tends to occur in the late second and into the third trimester. Again, it's more prominent in those with darker complexions, and it's also more common. And it's related to higher levels of estrogen and progesterone. It's also related to sun exposure, exposures to some cosmetics, as well as a genetic element. And it can be categorized into three main distribution. So centrofacial, so that affects the forehead, the cheeks, the nose, the upper lips. A malar distribution, which affects just the cheek and the nose. And then a mandibular, which affects more along the jawline. Moving on to striae, or stretch marks, which in pregnancy are known as stria gravidarum. They're extremely common in pregnancy. They affect about 90% of white women. They're less common in Asian and black women, but they tend to be more prominent in those darker skin. And they're dermal scarring, and that's caused by stretching of the dermis, the middle layer of the skin. They can affect the abdomen, the breasts, the thighs, and the buttocks, but they can really affect anywhere with significant skin stretching. Striae are linear changes. They tend to be purple or pink, although over time will fade to be paler and more white, and they occur at right angles to the natural tension lines of the skin. Then moving on to vascular changes of the skin. So if we move clockwise around these pictures, we can see four different examples of the vascular skin changes. So starting at the top left, we have varicosities, really common in pregnant women, affecting about 40%, most commonly as varicose veins or hemorrhoids of the anus, but they can also occur on the vulva and in the vagina. And they occur due to three factors: increased pelvic blood flow, obstructed venous return from the pelvis because of the growing uterus, and decreased venous tone because of increased progesterone levels. For most women, they resolve 3 to 4 months after delivery, but having varicose veins in a first pregnancy makes the woman more likely to have it in subsequent pregnancies, and they tend to be more prominent in every subsequent pregnancy after that. Then moving on to palmar erythema. This occurs because of dilatation of the superficial capillaries in the palms, because of higher estrogen levels. They occur in about 30 to 70% of pregnant women, and they most commonly affect those with lighter complexions. They're generally symmetrical across both hands. They tend not to be itchy and they don't need any treatment. They will just settle after delivery. The bottom right here, we have superficial thrombophlebitis, which is inflammation of a superficial vein because of obstruction with a small blood clot. They most commonly affect the legs, and they occur due to a change in blood clotting, essentially. So those women with prothrombin mutations, factor V laden, or anything that increases their propensity to clot will increase their risk. They're more common in those with varicose veins because the fact that they have varicose veins indicates that there's already impaired venous return. These can present with symptoms similar to that of a DVT, so it's important in these women that we refer them for investigation or exclusion of a deep vein thrombosis before we just label them as a thrombophlebitis. And finally, spider telangiectasia, named because of that central papule with the fine lines extending from it like the legs of a spider. They more commonly occur in the second trimester, and they're just a dilated blood vessel. They can occur on the neck, the chest, the face, and the arms. And they occur because higher estrogen levels cause a failure of the muscle surrounding that arteriole, meaning it can dilate. And finally, glandular changes. So there's increased activity of all the sweat glands in the body, bar the palms. So this can cause hyperhidrosis, which is excessive sweating, or miliaria, which we commonly know as prickly heat or heat rash. There's increased sebum production from the sebaceous glands, particularly in the third trimester. How that affects women is unpredictable, but those who already have acne can present with worsening symptoms. And finally, Montgomery glands. These occur in about 30 to 50% of pregnant women. They're brown papules on the areola, and they actually help with lubrication of the nipples and areola for breastfeeding. But they're again a normal change of the skin. So now that we've covered normal skin changes in pregnancy, I aim to talk about these 4 skin diseases of pregnancy. Starting with intrahepatic cholestasis of pregnancy, or obstetric cholestasis. Although it's not typically a disease of the skin, it does present with skin symptoms, which is why I'll talk about it today. So it affects 0.7% of pregnancies in the UK. The causes are poorly understood, and they're likely to be multifactorial, but in part they're related to higher estrogen and progesterone levels. These women tend to present in the third trimester, but they can occur earlier. Obstetric cholestasis is characterised by itch in the absence of a primary skin condition and with abnormal maternal bile acids, so bile acids above 19 micromoles per litre. Usually women don't have a rash, but they can have skin trauma from excoriation, from itching. Previously, we would have investigated all of these women for other causes of their abnormal bile acids, but actually the latest Royal College guidelines suggest that this should only be done on an individualised basis. However, these women do have a higher incidence of preeclampsia, so all women with obstetric cholestasis should have regular blood pressure and urinalysis screening. The role of treatment in obstetric cholestasis is only to reduce maternal itch. There's no evidence that medical treatment improves bile acid concentration or perinatal outcomes. So that symptomatic treatment includes emollients with menthol, antihistamines, although the evidence about antihistamines' effectiveness is uncertain, and it's thought that a lot of that effectiveness is probably just due to the sedating side effects. Ursodeoxycholic acid that we used to give everyone, no longer recommended. And we should only be giving vitamin K if there's evidence of reduced intestinal fat absorption or any clotting abnormalities. Raised bile acids do increase, are associated with a small increase in the risk of stillbirth. However, that level only rises above the background population level when bile acids are above 100. And the cause for that increased risk of stillbirth, again, is uncertain. It may be due to an anoxic event, to fetal arrhythmia, or because of spasm of the placental vessels. So for those women with mild and moderate obstetric cholestasis, their risk of stillbirth does increase above the background rate, but only at 40 weeks and 38 to 39 weeks respectively. So it's reasonable to offer delivery of these women at that gestation. But for those with bile acids above 100, their risk of stillbirth increases above the background rate from 35 to 36 weeks. So planned birth at that point can be considered depending on their other risk factors and, of course, the woman's preference. Women with obstetric cholestasis should have their liver function tests and their bile acids checked 4 weeks postnatally. Women who've had obstetric cholestasis at 4 weeks should have had complete resolution of their itch and completely normal bloods. If they're not, then it probably was never obstetric cholestasis, and these women should be investigated for another cause. And the prevalence of obstetric cholestasis in future pregnancy is increased. So women with a history of obstetric cholestasis should have bile acids and LFTs done as a baseline at booking. And moving on to the more classical skin conditions of pregnancy. So polymorphic eruption of pregnancy, or PUP, which occurs in the 3rd trimester. But actually 15% of women report that it began immediately after delivery, and it affects about 0.6% of pregnancies. It's more common in primiparous and white women, and there's an increased risk of it with excessive weight gain, multiple pregnancies, and in those carrying a male fetus. And it's thought to be caused by stretching of the skin, causing an immune response because of connective tissue damage. However, it's also been suggested that it may be due to low levels of fetal cells within maternal circulation. It tends to present with small pink papules around the stretch marks of the umbilicus, which then amalgamate to form these large hive-like plaques that you can see, and occasionally they can have small blisters within. It can spread to the buttocks, the thighs, the legs, and the arms, and this rash is intensely itchy and will cause significant sleep disruption. There are no reported effects to the baby. However, there have been a few rare cases reported where a baby can be born with a very mild form of the disease that's transient and seems to settle quickly. There's no real cure for it, so the mainstay of management is symptomatic relief with emollients with menthol, topical steroids. A short course of systemic steroids may be indicated in women with severe disease but with specialist advice, and antihistamines. For most women, their symptoms will resolve within 4 to 6 weeks of delivery, and it's unusual for it to recur in future pregnancies. Then we have pemphigoid gestationis. This is a rare condition that affects 0.002% of pregnancies. It presents in the 2nd or 3rd trimester, but can occur following delivery. And it's an autoimmune condition. So an immunoglobulin called PG factor binds to a protein called BP180. This causes tissue damage and blistering. The BP180 protein that's involved is actually found in the placenta. So it seems to be the placenta that triggers all of this as opposed to the skin. It's associated with other autoimmune conditions, but particularly Graves' disease of the thyroid. Again, it presents with an intensely itchy rash, initially around the umbilicus, and then it will spread to other parts of the body such as the trunk, the buttocks, over days to weeks. About 2 to 4 weeks after the initial symptoms, women can develop large blisters filled with yellow fluid, as you can see on the screen, or other women can develop these large plaques of inflammation on the top right there. Women can develop secondary bacterial infection of the skin. The PG immunoglobulin that's involved can cross the placenta. This leads to an increased risk of preterm birth, fetal growth restriction, and about 10% of pregnancies will present with transient blistering of the baby. That usually resolves over 3 to 4 weeks once baby's cleared the maternal antibodies. The diagnosis tends to be clinical, but some dermatologists will want to biopsy the skin. As with most of these skin conditions, the mainstay of treatment is symptomatic relief. But we also want to try and prevent the blisters and treat any secondary infection. We do this with topical steroids in milder disease, but more significant disease will require systemic steroids. Antihistamines and topical emollient with menthol can be used for symptomatic relief. For those women who don't respond to systemic steroids, they may require immunoglobulins or immunosuppressive therapy. This disease throughout pregnancy tends to have periods of exacerbation, then periods of remission, but about 75% of women will have a flare at the time of delivery. And it tends to take weeks to months following delivery to resolve. It usually does recur with future pregnancies, and these skin changes can actually recur with menstruation and with hormonal contraception. And finally, prurigo of pregnancy, which is a non-specific rash that again occurs in the second and third trimester, although it has been reported throughout pregnancy, and it affects about 0.3% of pregnancies. We don't know the cause, but it presents as erythematous groups of papules and nodules on the extensor surfaces, which are the back of the joints, so the backs of the arms, the fronts of the legs. And it's a clinical diagnosis that doesn't usually require any investigation. Again, treatment is symptomatic relief. That includes emollient with menthol, antihistamine, or sometimes a short course of topical steroids. Resolution usually does occur, but it can take several months after delivery, and there are varying rates of recurrence with future pregnancies. So I've talked a lot about menthol. As we've discussed, it's used in the management of most of these conditions, but what actually is it? So menthol is a compound that's been around for thousands of years. We have evidence of it being used right back to biblical times. And it's a compound that's derived from the mint family of plants, but actually most of it's synthetically produced now. It acts as a weak opioid antagonist, as well as providing a cooling effect and anti-itch properties. And it also has an element of antibacterial and antifungal property. Just to briefly talk about the science of itch, and apologies if everyone's feeling a little bit itchy at this point. So, itch happens because allergens or irritants activate itch receptors on the skin. These can either be from outside sources or from histamines from the immune system. This itch signal is transmitted up through nerve fibers, through various pathways in the spinal cord to the brain, where they undergo what's called itch processing. Itch processing helps us to identify that there's an itch, localize where it is, and determine the intensity of the itch. Scratching will temporarily relieve itch, but scratching itself also causes inflammation and irritation of the skin, triggering this whole pathway again. Although you do get a bit of a rewarding sensation from itch, and it can be addictive, scratching actually activates the reward center of your brain, which is why it's so difficult to stop sometimes. So how does menthol work on itching? The exact mechanism is unknown, but we know that menthol activates a thermoreceptor called TRPM8. And the exact mechanism by which it does this is unknown, but activation of this thermoreceptor creates a cooling sensation of the skin, which may reduce the sensation of itch, but also the activation of opioid receptors by the menthol may also reduce the sensation of itch. So how can we use topical menthol in pregnancy? So 18% of all pregnant women experience itch, and I'm sure we've all experienced how bothersome and detrimental this is to women and just their whole pregnancy experience. And as we've seen, the management of most skin conditions in pregnancy is simply through symptomatic relief. More generally, the cooling sensation that menthol creates in the skin can help with the sort of the hot flush experience that we can get with pregnancy. And it can be applied to the skin as often as needed for symptomatic relief. Research shows that 1 to 2% menthol in aqueous cream can be effective at reducing pruritus irrespective of the cause. And the most recent Royal College guidelines on obstetric cholestasis suggest its use for relief of itch with the condition. Menthoderm is a topical emollient that contains menthol up to concentrations of 5%. It's available over the counter for symptomatic relief of itch, and that also tends to avoid the delay in prescription times. It also contains a preservative called undesolenic acid, which can protect dry and irritated skin and reduce the risk of cross-contamination. Crucially, Menthoderm is also sodium lauryl sulfate free across their entire range, which I'll touch upon in a minute. So what cautions should we have with menthol in pregnancy? We should be cautious about the use of any emollient or emollient with menthol containing sodium lauryl sulfate in pregnancy. It can dry and cause irritation to the skin, which is crucial to avoid that whole itch cycle, especially in women who already have irritated skin or with skin already damaged by scratching. And as mentioned before, Menthoderm is the only fully SLS-free range. Evidence has shown that topical menthol is safe in pregnant women, but it shouldn't be applied to broken or damaged skin. We should also be warning women who smoke or who are around open flames, and that there is a risk of ignition with aqueous cream near open flame, just to be aware. And finally, just to briefly discuss antimicrobial lubricant, so Hibitane obstetric cream. So we know that the number of vaginal examinations performed during labour may be directly correlated with febrile morbidity. Hibitane is an antimicrobial lubricant that contains 1% chlorhexidine gluconate, which is an antiseptic that's effective against both gram-positive and negative bacteria, fungi and viruses. Vaginal cleansing with chlorhexidine reduces the risk of neonatal colonisation of group B streptococcus, and it's also been shown to reduce early neonatal and postnatal infections and post-caesarean infectious morbidity. Hibitane can be used as a lubricant, and it has a range of different uses in obstetric care. It can be used for any vaginal examination, to aid spontaneous deliveries, and with instrumental deliveries. We know that prevention of any infection is better than cure, especially in those women at high risk of morbidity and mortality from infection. And that's everything I have to say about skin in pregnancy, but I'm happy to take any questions that anyone has.